everyone in from the waiting room. So I think we'll go ahead and get started. I'll do a little bit of an introduction before we get into the meat of this evening's discussion. So welcome. My name is Stephanie Shivers. I am the Chief Innovation Officer and Vice President of Program Development at CaringKind. And it is my pleasure to be with you all this evening for tonight's talk, which is Understanding Dementia 101. This particular talk is about signs and symptoms of Alzheimer's and other dementias. For those of you who have been involved with CaringKind before or heard this talk or seen this talk, this is the first of what's a 3-part series. You don't have to do them in any order, but there's really 3 different pieces of understanding dementia, which we're now calling our Dementia 101 webinars. And so this is the first one, and there'll be 2 more in December. And one of those will focus on different stages and the abilities that people have across the dementias and as symptoms progress. And the other one will be about adjusting to a new diagnosis and what that's like for both the person living with dementia and family members and friends who are supporting them. But this one tonight, we're actually talking about kind of the difference between Alzheimer's and other dementias and why they matter or why they don't matter, depending on what a person's situation is. I am joined this evening by Dr. Ann Kenny. We're going to tag team a little bit on this conversation tonight. Tonight, we're talking about understanding dementia, the signs and symptoms of Alzheimer's and other dementia. Before we get started, I want to just kind of frame this conversation for us a little bit. So we're going to be talking tonight, really, we're going to share some information with you about the different types of dementia, the ways they affect people, some of the causes for them. And we want you to have kind of a broader understanding of what dementia is in general, what memory is. And so we're going to go through a little bit of kind of basic education so that when we talk about the symptoms that present in people, you have some understanding of what to associate those symptoms with or why they might be presenting in the way that they are. But ultimately, we want to know kind of what difference does it make if you have Alzheimer's disease or Lewy body? Is there a difference? What is the difference, and why? Why does that particular difference, matter for us? But before we start, let me just kind of get us all on the same page and an understanding of what is dementia. And so dementia is it's an umbrella term that we use, much like cancer is an umbrella term, which is it's a general term that covers several different types of diseases or disorders or syndromes, which all describe, it's a category of conditions that all have, what they have in common is that they deteriorate the brain in one way or another. And that those brain changes impact a person's ability to engage in their everyday activities and in their relationships. And so kind of under the umbrella, you can see we have Alzheimer's disease, vascular dementia, Lewy body, frontotemporal. We're going to be talking a little bit more specifically about those in a little bit later. Another way to think about dementia is, we talk about things like fruit. Fruit is a category, and there are different types of fruit. So there are apples, there are pears, there are grapes, there are bananas. Those are all different types of fruit, but the upper category is fruit. It's similar with dementia. Dementia is the kind of the umbrella term. It's the upper category, like cancer. There's cancer as the umbrella term. There's different types of cancer: breast cancer, pancreatic cancer, liver cancer, cancers of the blood. But cancer is the umbrella term, so dementia is the umbrella term. And these different types of dementia are going to cause a decline or a change in one and ultimately several of the items that you see listed here: memory, executive function, visual spatial function, language processing, movement, muscles, and sensory functions. And I'm going to go into a little bit more detail of what those technical words actually mean. But before I do that, let me just give you a little bit of general information. We're going to do a little bit of brain work ourselves this evening. And I'm going to show you. So this is a rendering, a picture, artistic picture of a brain. And you can see the front of the brain there on the left side of your screen, and the back of the brain. This is the left, it's called the left hemisphere, the left side of the brain. And the right side of the brain from the outside would look pretty similar, but functionally there's different parts. They function differently. But when we look at this, it kind of just looks like a, squiggly little spongy, all the same color, it's hard to believe that something that looks like that can have so much control and really house so much of who we are. But that brain is actually divided up into a number of different areas, and all of these different colors represent and show you kind of we know that all of these colors, we know what happens in all of these different parts of the brain. So our brains, even though they may look very homogeneous, it's actually very organized and specific. And so there are locations in the brain, and we know what different functions those different parts of the brain actually control. And this is a really detailed example of that. And I promise there won't be a test on this later, but I think that it's helpful for you to see this, because you can see, like over here, this green part of this brain up here on the left, number 2, this is actually where memory and emotion is housed. This is called the temporal lobe. We know in the front here, this red part, this is where thinking happens. This is the frontal lobe. We know, the parts of the brain that control how your arms and your legs work, and how your fingers work, and how when you feel something with your, with your muscles, and when you feel something through your skin, we know where that is located on the brain. We know that vision actually happens in the back part of your brain back here. We have an eyeball, information comes into our eyeballs, but our brains are what actually cause seeing to happen. On this one here, you can see that emotion happens in the center of our brain here, kind of deep inside. Smell is in there. And then this is very kind of close to where those memories and emotions are housed. So the reason why I show this is because this answers some of the question, why does it, what's the difference? And so what we're going to see as we go along here is that different types of dementia affect different parts of the brain. And so it may, if it is impacting the front of your brain, you may not necessarily have, memory issues. You may have more thinking issues, or you may have more vision issues, but not have thinking issues. If you have more, if it's up here, you may have more problems with movements, or in the cerebellum, this kind of brown, nutty looking thing down here in the back. That's where all your smooth movement happens. And so depending on where the brain is impacted, that's what we're going to see as far as kind of what we call symptoms, signs and symptoms of the type of a dementia that a person has. And particularly early on, the symptoms will differ from whether it's an Alzheimer's disease or a Lewy body disease or a frontal temporal disease, dementia. You can, someone may look very different with the challenges that they're having from their particular disease process. As the disease progresses, the symptoms become similar, but initially they can be a little bit more differentiated, and how you support somebody may be a little more nuanced because of where and how their brain is being affected. So this gives you a little bit of a better vision of what I'm talking about here. So on the left, this is an image with kind of an overlay of color that shows you. So in Alzheimer's disease, you can see that the majority of the brain is affected in this kind of hot green area over here, this light green area. This is where again, where memory is really housed, is over here. Whereas in frontotemporal dementia, this front part of the brain, which is really where higher thinking happens, is more impacted. So that brain looks like, kind of a soft, spongy material. And it looks, again, like pretty nondescript, but in reality, it's really this very intricate network of a type of cell that's called a neuron. And the neurons are kind of these wiring systems that are closely connected to one another. And they communicate with one another. So it's like a massive, big highway system, which I think that this is Stephanie's version of how do you think of how the brain is actually built? For me, it's really like this big highway system with, cars and, transportation is happening on all of these roads, and information is going from one part of the brain to another part of the brain, which ultimately ends up in us being able to think and talk and walk and eat and have relationships with each other and to feel, and all of the things that are part of being alive are governed by this highway system and the transportation that's happening on these roads in our brain. And what happens in Alzheimer's disease or other dementias is that something goes wrong, and that dysfunction, which largely involves different proteins, different type of building material that's in our brain, it goes awry. It goes off for some reason, and so it can create like clusters of junk in the middle of the road, and so the traffic can't go through, the signals can't go through because there's literally junk in the way. So that's one challenge that happens. Another challenge that happens is kind of the rebar, like in a road, we have these kind of steel, there's kind of steel reinforced concrete that makes up roads and bridges. And it's like that, those steel bars twist and turn. And so the road breaks apart because what's holding them together is now broken apart. So that's kind of another mechanism. Another mechanism is there may be like an extra thing that grows up in there. So in Lewy body, there's another protein that grows up in there, and it's kind of like having, the junk in the middle of the road. And this is another artist's kind of rendering of what does that actually look like kind of in cells. So, this is the equivalent of having, that big ball of junk that's in the road. It's blocking the path so the signals can't get through. And inside this one, you see those lines that's like the rebar that's ultimately pulling apart, and so then the cells die. And ultimately, all of these things end up causing the part of the brain that has the dysfunction or the disease, those cells end up dying. And so the overall function of the brain, the signals, the information can't transfer, the overall size of the brain decreases, and the parts, all of those kind of colorful parts that we saw earlier on, some of those colorful parts will disappear because the brain cells have died in that particular area. There are some wonderful videos that are out there. I've got resources in here, and when we put the slides up, we'll put links to all of these different websites. But the National Institute on Aging has a wonderful website where there's all different kinds of videos, lots of information and resources on the different types of disease. And particularly, there's a wonderful one on Alzheimer's, Lewy body. They're all there. And so I would definitely encourage you to watch those 3 or 4 minute videos to get more information if this is helpful for you, if you're looking for more information. So Alzheimer's disease, Lewy body, vascular dementia, what's the difference? The cause for the disease is one of the differences. So that the technical term is like, what's the pathology? That's kind of the medical term so the cause of Alzheimer's is different than the cause of Lewy body disease, is different than the cause of vascular dementia. We're going to get into those in a little bit here. And what difference does it make as well, depending on where the brain is infected, a person's going to experience different symptoms that are related to where on the brain, what structures in the brain are being affected by the disease or the disorder. So let's talk a little bit about memory, because memory tends to be one of those, one of the areas that's impacted, certainly in Alzheimer's disease. But I want you to understand that there's different types of memory, and some of them are affected and some of them are not necessarily affected, or some may be affected earlier and others might be, have challenges later on. But at least I want to give you kind of the information, so hopefully it'll help to make some sense for why people can remember one thing and not the other thing. So the first one is what we call is short-term memory, and short-term memory is really built up of what we call episodes. And so it's really about recent events or recent episodes. So short-term memory is, what did you have for breakfast? What did you do yesterday? It's things that are, in the recent past, like what are the things that a person did or what is happening that they're looking to remember. Long-term memory is what's happened in the past. And so if you think about your short-term memory, those are recent episodes, right? Whereas long-term memory those are episodes that happened years ago, or are in the past. And so I've got, this is the, Apollo 11 team here that, when we had the first men on the moon, I think we can all kind of remember that. That's an example of our long-term memories. I mean, I remember where I was when we watched the little television, when we saw, the first step on the moon. And so that's part of our long-term memory, I'm remembering when my children were born, or, my high school memories, or when I got married. Those are a part of my long-term memory. Another type of memory is what we call semantic memory. And again, there won't be a test on this, I promise. But semantic memory is this is our kind of understanding of facts and things that you kind of just know. They weren't necessarily things that happened to you, but things that you know. So, we know what a car is. We know what a television is. We know that, that the sun rises in the morning and sets at night, and that the moon's going to come up, and that there's stars up in the skies. Those are kind of basic things that we know and understand, but it wasn't, it's not the same as, I remember what television shows I watched when I came home from school when I was in elementary school, Gilligan's Island, Lost in Space, right? That's long-term memory because those were episodes. But knowing what a television show is, that's more semantic memory. And then there's two other things that are kind of fall under the memory category. And one is called procedural memory. And this is kind of your remote pilot memory. So the things that you do without thinking about them. So, there's all of us have a certain way that we brush our teeth. And, no one, you don't have to think, do the left. Well, I do now. I think about it, do the left, lower, left, right, upper. But you have a certain way that you brush your teeth. There's a certain way if you get in the shower. There's a certain way that you wash your hair or wash your body. And we would probably see you do that the same way every time. If there's a certain, you get up, you make your coffee a certain way, or you make your breakfast, or do you put your socks on? Like, how do you get dressed in the morning? What's your particular method? You're not necessarily thinking about it because it's encoded there in your brain. That's called procedural memory. And then working memory, this is where you've got a new piece of information, you're keeping it in your head, and then you're going to use it in some fashion. So it's actually not technically a part of memory. It's really a part of your frontal lobe, which I'm going to get into here in a second. But it tends to be something that we think about as being our short-term memory, but actually it's not. It's information's coming in, you're working with it, you're keeping in there. It could become then a short-term memory, but not necessarily. It's what you're attending to kind of right now in this moment. Actually, I'm going to go back here for a second. So why do I share all this information? Because what you see often in folks is that short-term memory is something that's definitely impacted, particularly in Alzheimer's disease, where people will be able to, they maintain their long-term memory, but they may have more challenges with short-term memory. They may remember semantic memory things. Procedural memory stays intact well into people's disease. So I'm actually an occupational therapist by background. And when we can actually teach people kind of in the moderate stages and then close to the later stages how to do new things by working procedural memory. You basically teach people how to make something a procedure, because procedural memory is actually in a different part of the brain than short-term memory, which is in that green, that green section on the side. Language is another thing I want to talk about. So we talked a little bit about memory, we talk about language. So language is really, again, a broad category, but there's a lot of pieces that go into our ability to speak and to communicate with one another. And so part of that is, I'm actually using what's called expressive language right now. I'm saying words, they're coming out my mouth. There is a motor function that my brain controls in order to be able to get those words out of my mouth. There's knowledge that goes with what the words are so that the correct words are coming out. And you are actually experiencing what's called receptive language. So you're hearing those words, but you're understanding, you're making sense of the words that I'm actually saying to you. So expressive language is getting the words out. Receptive language is understanding what those words mean. Both of those could actually be impacted by a dementia. You hear, and you see kind of this phenomenon of having something like at the tip of my tongue. It's like I know the word that I want to say, but I actually can't get the word out of my mouth. I can't pull the right word. You may see people where they pull a related word, but it's not the correct word. So one that comes top of mind to me right now is referring to, someone's referring to their son as opposed to referring to their husband, or they may, substitute one name or another. It's an important relationship, but it's not the correct relationship. So all of those types of language, production, understanding, and communication, all of those can actually be impacted by different types of dementia. And then finally, I want to talk about this concept of what's called executive function. An executive function it's called executive function because it's really a metaphor for thinking, if you think of a business executive or like a chief executive officer, they're kind of in charge of things. They're in charge of kind of organizing and running things. And that's what the executive function purposes of our brain do as well. Executive function is housed in the front of our brain here. It's the last part of our brains to actually develop. When my children were younger, I have a 27 and a 30-year-old now, 2 boys, and I used to say, it's the part of the brain that I'm waiting to grow in for my children. Happy to report it's continuing to grow, and it feels like it's almost fully functional now. But it is these are the higher thinking skills that we hone in our adulthood grow into in our adulthood, and that are the highest level cognitive skills that really separate us from kind of lower level animals. So executive function is really an important part of our brain, and they control so many of our actions and reactions and the ways that we interact with the world, which is why having this part of our brain be impacted by the dementias is so has such magnitude for people's lives. And so executive function is really responsible for organizing and gathering information. And we do that through like paying attention and planning and problem solving and having that working memory, you know, being able to take information in and work with it together and then kind of spit out a solution to something, being able to think abstractly about something, being able to pay attention to something and to not pay attention to something else at the same time. All of that is a part of the way that we organize information and we structure it so that we can work with it and evaluate it and do something with it. And then the second thing that our executive function does is what's called regulation. And this involves taking that information, evaluating it, and then making a decision or responding to what we have, what we've taken in, what we've attended to in a certain way. And so this part of our executive function is responsible for our being able to take action or to start an action or to stop an action. This is the part of our brain that allows us to exercise self-control, that allows us to kind of regulate our emotions instead of letting them run wild. Or, you know, it's the part of our brain where we say, I hear that, I understand that, but I'm not going to actually react to that this particular moment. I'm going to, you know, wait. It's the part of our brain where we say, might not be socially appropriate for me to do X in this setting. So that part of our, you know, those higher decisions are all a part of executive function. And so when executive function changes, then we start to see problems that people experience. And these, I think, for those of you who are experiencing cognitive changes yourself, or who are, you know, who are in relationship with, you know, or married to someone or supporting, or if you're an adult child, this is what you tend to see happening with, you know, the people who are diagnosed. So you see them having difficulty organizing things, inability to multitask or to switch their attention from one thing to another, difficulties planning or getting started with something, initiating a particular task or activity. They may have trouble planning for the future because the future is an abstract concept, and so that's kind of a double whammy, both having difficulty planning and being able to think about how what I'm doing now would affect or impact the future. Having difficulty processing information or storing information or getting the information out of their head, that's executive function. Mood swings, again, that kind of the emotional regulation, so you can see people go up and down, that's executive functioning. We also see things like people who may have been very concerned about something historically now start to have lack of concern for it. So, you know, you may see a change in a concern or care for others, a loss of interest in, you know, favorite or particular activities, socially inappropriate behavior, which is uncharacteristic, inability to learn from consequences or past actions. This is an important one. I use the example of, you know, having bad food in the refrigerator. So like, why do we throw out bad food? Because you know that if you have bad food in the refrigerator, and if you eat something that's bad, you can get really sick from that. And that's an inability to see that, there's a consequence here if I let that go. If I do that action, there's a consequence, or I may have actually had food poisoning in the past. And so therefore I know, I'm not going to do that again. difficulty with abstract concepts, and then again, unawareness or denial that their behavior, what they're doing, that there's a problem with what they're doing. Because being able to make a judgment on, is this appropriate or not? Is this unsafe or not? That's an evaluation process that happens in the front, in the front part, and that executive function part of the brain. So I think this is executive function is, I know that's a little bit of a dry information, but I think it's really important because that, when, as we age and as we become adults, we tend to interact with our jobs, with each other, with the daily things that we do, like paying the mortgage or making sure the bills are paid on time, or making sure that the lawn is taken care of, or making sure that the electric bill is paid. All of those activities revolve around executive function. And particularly in relationships, if you're having dialogue about things that you're doing or things that you desire or things that are important to you, all of those are based in higher level cognitive thinking. And so when one person starts to have a challenge with higher cognitive level thinking, the stress that's on the relationship and the way that you interact with each other can become very challenging and very difficult, because your way of interacting has been based in these higher cognitive level functions. And so it's a real shift on thinking then, okay, what difference does it make? Well, now you can't actually logically work through an issue that you may have been able to work through before. You may not be able to convince someone to do something or not to do something, because that involves a logical process that the person may not be able to do anymore, they may not have that ability because of the change that's happening in the brain. So there are other things that are changing as well. As I said, vision happens in the brain, and so visual spatial processing speed. I'm just going to go through these a little bit, but I want to draw your attention here in the corner. There's a wonderful book that was actually created by people who are living with dementia, who talk about the sensory challenges that they actually experience. And so this is the link is here, and again, we'll share this with you, but this is a wonderful kind of book written by people who are living with the experiences, sharing about what those challenges can be like and some of the strategies they have for working with them. But these pictures kind of depict some of the other challenges, but let me highlight a few of them. Excuse me. Visual spatial changes. This is one that doesn't necessarily, come to mind when you think about people with dementia, but it's really a significant issue for a number of people. And so visual spatial abilities are, your eyes are seeing something that has a question of, it's what's the distance or what's the relationship between what you're seeing and how much space or how far away something is, and being able to judge that distance or how information gets put together. Those are all related to this visual spatial part of the brain. And so for those of you who are familiar, you may have heard of kind of the clock drawing. That's a typical diagnostic tool for people with Alzheimer's. So you can see here on the right, a clock, you've got a 12 and a 6, and the numbers go around, and kind of a very, the space is all the same. But somebody with Alzheimer's disease, their ability to put the numbers kind of in the correct space can be off, because they don't actually have that visual spatial challenge that's actually happening in their brain. Another place that we see this was with people with driving. And so being able to judge kind of where the car is in relationship to another car, or, a telephone pole or the curb. They may misjudge how close something is. Somebody might grab for something and miss it because they think that they're hitting the target, but because their visual spatial ability is off, they miss it. Processing speed is another big factor that changes. And so processing speed is how quickly can you react to something, as well as how quickly can you understand something. And so I speak relatively quickly, and a person with Alzheimer's or another form of dementia may struggle to kind of keep up with the pace of my speaking because it's taking their brain longer to actually take that information in, kind of hear the words, make sense of the words, put them together, and then understand them. And so this experience of information overload can happen, or shutting down can happen because there's too much information happening, or a person's ability to attend to the speed at which information is coming can be compromised. This is one of the reasons why driving is an issue, because reaction time gets slowed down or can be off. And then there are physical changes that actually happen over time, especially as people progress into kind of the middle or the later phases, because again, the brain is controlling all of those physical aspects of a person's ability, both externally as well as internally. So people start to have difficulties with walking and being able to move. And so they may end up needing a wheelchair. And as people are experiencing, changes in their ability to move, their ability to swallow also changes. And so people can have coughing and aspiration because the muscles which are normally moving food through the mouth and swallowing can be compromised, which leads to things like an infection. And then a person's ability to fight the infection, which is a brain function, can also be compromised. This photograph down here on the bottom, some of the Lewy body or Parkinson's disease, Parkinson's dementia, the person's ability to have facial expressions, those are also impacted because your brain controls the muscles and the nerves in the person's face. And so there are lots of different types of dementia, and I'm actually going to have Dr. Kenny and actually go through these a little bit more specifically for you all. This is kind of just high level and introductory conversation. And again, there's more information that we can actually provide, or we can, point you to additional resources for any of these. So we're only going to do a few, but I wanted you to be aware that, we're going to kind of do the 4 major dementias this evening, but there are lots of different types of dementia, and you're hearing kind of more and more about them, thankfully, in the news as we learn more about what the brain diseases and disorders are, and how we can be helpful and make a difference to people, or hopefully kind of change the trajectory of disease and through lowering risk and lifestyle changes. But let me turn it over to Dr. Ann here to walk us through Alzheimer's and some of the other primary dementias. So I'm going to put myself on mute here and and actually before Ann starts, so Dr. Kenny's a geriatrician and palliative care physician and has been an academic researcher for a long time, and we are privileged to have her work with us at CaringKind. Thanks, Ann.
Thank you. Thank you, Stephanie. And because of Stephanie's excellent talk, I think this will be fairly easy. We are just going to talk about a few different kinds of the dementias under that umbrella. Alzheimer's is the most common of the dementias. It's thought to occur in about 60 to 80% of the dementias, or co-occur. Some of these dementia, you can have more than one type at a time, but it is caused by they're under the umbrella of dementia, and even under the umbrella of Alzheimer's, there are probably a few different dementias that we're talking about. But we do know that plaques and tangles occur, plaques from the amyloid excess and tangles from the tau uh, proteins that Stephanie was talking about in the roadway analogy. And then because of those plaques and tangles, there is a loss of connection between the nerves. And I think Stephanie described that very well. This occurs on average over about 10 years from the beginning of symptoms to end stage. But the idea that this is happening occurs at least 10 to 15 years before even the first symptom occurs. And that's becoming more important to us as we are looking for ways to change the course of the disease or keep things earlier in the course of the disease. Because once the roadway has broken or once something is too mangled, you can't necessarily undo it. But if you can get some kind of intervention going early enough, maybe we can prevent some of that damage being done. And so that's when people are talking about lifestyle changes or increasing your cognitive reserve. And so it's important to start looking for some of these symptoms. Frequently, the symptoms are usually occurring in the mid-60s in most people, but they can occur earlier. In Alzheimer's disease, most people first mention memory problems or having difficulty remembering events, following conversations. Other things that people will talk about are word finding problems, visual spatial issues, little fender benders are what people frequently talk about, or I think part of that visual spatial is that getting lost. It's not just not remembering where you are, but kind of being a little bit, your maps don't match up in space any longer. Some people will talk about reasoning and judgment, but again, it's one of the more common of the diseases, of the dementias. It often is going along with some of the other dementias, which I'll start talking about now. And Stephanie's in charge of the slide, so we'll go to the next slide. The second most common cause of dementia is a vascular dementia. This is when Stephanie was talking about some of the things that can get in the cells and damage them, the proteins that can build up, the abnormal proteins. Vascular dementia is a little different in it's the blood supply to the brain. So that can be from several causes. It can be from a major stroke, and most people know if they have a major stroke, but that could leave you with some changes in your cognition. But there's also some like what we often refer to as mini strokes that you wouldn't even realize you're having a stroke. The symptoms of vascular dementia can be very similar to Alzheimer's disease, but it could also be a little more spotty, where you might have an intact memory, but a lot of word finding problem or reasoning problem. Or you could have your memory not so good, but your judgment is excellent in that area of it. So it all depends on what area of your brain is affected. And again, the graphic of the different parts of the brain, you can imagine if one part is not getting a blood supply, that part might have more impairment. So you might have difficulty walking early in your disease with vascular dementia, where most other dementias, if the walking is impaired or when the walking is impaired, it's later in the disease, because by then that's when that area of the brain has lost enough function. But if you have poor blood supply to an area, you may have that loss earlier. When the most common mixed dementia is usually Alzheimer's and vascular. The two seem to have similar risk factors. They seem to kind of go together in ways. But the difference with Alzheimer's disease is it's considered a slow progressive decline. With vascular dementia, people think of it more as a stepwise, where you're doing fairly well, you see not many changes, but then you have a drop in function, something happens, you notice a big change, and then you may stabilize for a bit of time and then have another big stepwise change, a big decrease. Um, in most dementias, it's always it's always a progression, a progression over time of a worsening. With vascular dementia, there can be a period of worsening during one of those steps. You may have some improvement in function for a bit, but in time, it's much like a stock market that's going down rather than a stock market that's going up. And I don't, this is the treatments or the way you handle a vascular dementia versus some of the other dementias is you look for things that affect the blood vessels. So it's similar to heart disease. So you would be looking for changes in your diet, changes in your cholesterol, because if blood supply is clogged by cholesterol, for example, you would take care of things that may cause an embolism from your heart. So atrial fibrillation may give you blood clots that go to your brain. So you would treat those things. You would treat high blood pressure because the high blood pressure puts a strain on all those arteries and they start to weaken. There's other things besides cholesterol that can clog arteries. Amyloid is one of angiopathies can happen, and those are less common, but can occur as well, and those can result in a vascular dementia. And I would go to the next slide. So the next type of common type, but not that common, in about the 10% range, is frontotemporal dementia. This dementia it is mostly, much like its name, it mostly affects the front and the temporal area of the brain. And it's hard to diagnose because a lot of the symptoms, especially the early symptoms, are very vague or difficult to tease out from other things. Most people who are diagnosed with frontotemporal dementia, the diagnosis occurs fairly young, somewhere between 45 and 65. And so it's the symptoms, which can be difficulty processing, thinking, behavior, mood swings, the apathy, that difficulty getting things initiated, maybe being inappropriate because of the Stephanie was talking about where a lot of the regulation of your emotions comes from the frontal area. And so people may be having difficulty at work and quick to anger because they're not filtering that anger when they get frustrated, or maybe not understanding social norms anymore and starting to make passes at people, or saying things inappropriately and not realizing that it's inappropriate, but because they're in a relatively young age, it is thought to be socially inappropriate, and therefore the consequences are not, oh, let's look for a disease, but let's so-and-so's not working out at work anymore. So unfortunately, it's a difficult disease to diagnose at first unless one is really looking for it. The other is that there are several types of frontotemporal dementia. There's a behavioral variant, and that's again when things are much more from the frontal lobe, and it's those behaviors we were just talking about. And what's funny is that it can be very on and off. No, I'm sorry. So the behaviors can be erratic. The and this is what people feel is very difficult to emotionally handle themselves, because they realize that one day they're losing their temper, and the next they're not understanding why. There's another type primary progressive aphasia, where it's a little bit more located in the temporal lobe, but people have a lot of difficulty either with word finding or understanding words or beginning to write words, or losing their language. And that's another variant of primary progressive aphasia. All of these will go on to be a bit more global over time, but these are how they present. And then the third type, which is less common than the behavioral, which is the most common, the primary progressive aphasia of the frontotemporal dementias, the next most common. And then the movement disorder aspect is associated with things like supranuclear palsy, which people can show up with walking difficulty or postural difficulties, often can be confused with Parkinson's disease, often happening much earlier with a cognitive variant as well. I think there's not much more to say about frontotemporal. And then Lewy body disease and Parkinson's disease. This is caused by an abnormal protein that is deposited in the neurons. This same protein can be used for synaptic control. Most of us have it, but in this case, it gets stuck in the neuron and starts to cause neuronal death. This one can also be difficult to diagnose in the beginning, that people can have really good days and then really bad days. There's often, it can begin younger, much like frontotemporal dementia. The cognitive fluctuations can be dramatic. One day someone can seem very, very confused, and another day seem perfectly normal. So that often people are thought to be faking it or doing it on purpose, having a bad day on purpose. There's several hallmark things that can show up. One is hallucinations or miscalculations. I can think of several patients who would have a tree, like a coat tree, and they would think there was a person in the room. They were just misrepresent that it wasn't a hallucination, and that the coat tree was there, but they saw it as a person. But they're also known to have multiple visual hallucinations. Movement disorders can go with this. So, and sleep disorders. If you've heard of rapid eye movement disordered sleep, where somebody is basically can act out their dreams quite aggressively. They don't lose the motor control during their sleep, fall out of bed, hit the bed partner, but they're dreaming and they don't mean to do it. That's one thing. A lot of mood disorders can go with this, apathy, anxiety, depression. So again, early on, the sleeping issues, the fluctuations, and the mood issues can make it difficult to diagnose. People with Lewy body disease and Parkinson's disease can have other physiologic changes, like really high blood pressures, really low blood pressures, fainting, incontinence, loss of smell. And so when they're being diagnosed, sometimes if the cognitive issues or a lot of these other issues lead before the symptoms of Parkinson's disease, before kind of the motor, it's considered Lewy body disease. If somebody begins with Parkinson's disease, has a lot of tremors and motor issues, and later in time develops cognitive, and not everyone with Parkinson's disease will develop the cognitive parts of Lewy body disease, but about 40% of people with Parkinson's will have some cognitive loss in time. They're starting to be considered the same disease. One of the other important things to remember is this is a group that if they're given an antipsychotic, they usually have a very marked bad reaction to that. And so most people, and in fact, some people are diagnosed this way when they're thought to have a different type of cognitive loss and are given an antipsychotic and have a very bad reaction to it. People will start to look through the picture a little bit more clearly to see if they in fact have an aspect of Lewy body disease to their diagnosis. And then there are several others, and we haven't even named them all here, but you may have heard of something like Creutzfeldt-Jakob disease. It's similar to mad cow disease. It progresses very quickly and it's very rare. Huntington's disease, which is a genetic disorder transmitted to it's a autosomal dominant, so it's quite aggressively is passed down into children. Most people get symptoms in their 30s to 50s, and it has uncontrollable movements as well as the cognitive changes in time. Korsakoff syndrome is from severe thiamine deficiency, and it's usually related to alcohol a misuse disorder and malnutrition kind of in combination. And or it could just be due to malnutrition actually. And then Down syndrome is associated with a very high risk of Alzheimer's disease due to the genetic anomaly that causes the Down syndrome itself, and increases the risk with 30% of individuals living to age 40 having cognitive changes. In addition to their developmental disabilities, they will have then classic changes, neurodegenerative changes of Alzheimer's disease, and about 50% at age 50. So if somebody with Down syndrome, now that we are treating Down syndrome, the cardiac issues, which used to cause most people with Down syndrome to die at a young age, and those issues are being sorted out much more clearly. Now there's an issue with Alzheimer's being coexisting with Down syndrome. Okay.
Thanks, Anne. So hopefully now you have a little bit, again, bigger picture as to, what's the difference between these different types of dementia. And as Anne said, we've only kind of highlighted kind of a few of the big ones, but I think one of the important differences that now hopefully that you can see is that they are actually different disease types, and they're under this umbrella of dementia, but they are very different diseases. And kind of historically, Alzheimer's disease was kind of the big named one, and so recognizing that, I think it's important to recognize that Alzheimer's isn't the only dementia, and so understanding, which is why kind of using a term like dementia is a little bit easier than just calling everything Alzheimer's, which kind of it's been historically done, because there are significant differences for folks. And so what's the difference? There are definitely different causes for the diseases, different symptoms, different ways of presenting the way that the brain diseases actually present as far as symptoms and signs go. But I want to, now that we've kind of shared that information and provided that kind of level setting, I want to pivot a little bit, because what difference does it make? Hopefully by going through this, you can see that, the people's brain changes affect the way that they're interacting in their everyday activities and in their relationships. And those early symptoms are very similar to other symptoms, or, to symptoms that people have from different diseases. And those symptoms are really indicative of living with a disability. And so people are, in fact, because these diseases are chronic and they are progressive, but as Anne was saying, it can take 10 years. People can live with a disease for 10 years or 20 years. And so that is a very different experience than other diseases where you live for a shorter period of time. And so I think it's important to realize that people are living with a cognitive disability that ends up becoming a physical disability, which really ends up becoming a fatal disease. And so there are kind of these distinct phases of what people's experiences are and how we support people as they're living kind of through the trajectory of their diseases and disorders. It's helpful to think about that disability mindset, because then we begin to identify what are a person's strengths, how do we support their well-being, and those become primary as they're learning to compensate for the changes that they're living with. I wanted to, it's one thing for me to talk about living with a cognitive disability. It's another thing to hear directly from people who have a diagnosis and to hear them talking about it. So this concept was really championed by a gentleman named Richard Taylor, who was really one of the first people who was living with Alzheimer's disease to come forward and to really be public about it and to begin to advocate for a different different types of services, different types of approaches, and particularly to view people with Alzheimer's differently. And so Richard, who died from a different type of cancer maybe 5 years ago now, he talked about, and he said here this quote, "I'm not dying from a disease, I'm actually living with a chronic cognitive disability." And then the second picture, this is of Kate Swaffer, who is Australian, and was diagnosed in her 50s with young onset Alzheimer's, and she's now, I think, in her 70s. But she's been living with Alzheimer's for, I think close to 20 years now. And Kate says, it's clear we need to move from a medical model of care to one that's based on a social and disability pathway of support and care. A key issue is changing this is recognizing the symptoms of dementia as disabilities. The symptoms caused by dementia are cognitive disabilities. We don't tend to think of dementia in the disabilities realm. We tend to think of dementia in the disease realm. That's the medical realm, which Kate's talking about here. But the way people are living, and particularly with new kind of disease modifying treatments, our hope is that we would be able to diagnose people very early, even before, we start having symptoms, and that we would be able to keep people in the early stages, or we would slow the progression so that people don't actually develop symptoms over time. So this idea of kind of shifting our mindset to supporting people with disability, living with a cognitive disability, or even a physical disability, we certainly have real role models in that arena. And, here's a photograph of a few of them. These are people who have been living with a disability for for their entire lifetimes, and some who are living with a disability that they ended up dying from ultimately, or will die from ultimately. But they've certainly had significant impact on the world, and have been able to be real contributors and to live vital lives in spite of their disabilities. And I think, at CaringKind, that's really, a large part of the work that we are involved in, particularly with our folks who are involved in our early stage programs, because we want to be able to support people to live in an experience of well-being. And there are wonderful resources and tools out there now, thankfully, to help individuals and families to do that. And I wanted to highlight a few of those here tonight. I'm conscious of our time moving on here, so I'll go through this quickly, but I want you to know that there are resources available, and these are free resources that are available to you, and we can, again, we'll put those in the resources, but you can always reach out to us, and we can point you to them. But this first one here, Pathways to Well-Being with Dementia, this is a manual of help, hope, and inspiration. This is about 250 pages that's co-written by people living with various forms of dementia, family members, as well as professionals. And, some of the highlights that they talk about on, how do you actually support a person's experience of quality of life or well-being is staying connected, finding fun and interesting things to do, limiting stress, eating and drinking healthy, getting restorative sleep, being physically active, keeping your spirits up. You'll see these themes kind of are repeated, and the ways to do it are repeated over and over. This is an example of a guide that's one of a group of guides called the By Us, For Us guides. These come out of Canada. These were written again by people living with dementia. There's about 20 of the guides all together. And this one is called Tips and Strategies. And this is really about what are tips and strategies for living well with a form of dementia. And so adding in safeguards, minimizing stress, using visual aids, Post-it notes, calendars, using technologies, developing routines, keeping life simple, keeping your sense of humor in spite of things, planning ahead, communicating your needs, and connecting to peers. So the takeaway here is really, continuing to support people to be involved in things that are meaningful to them, whatever that looks like for an individual, depending on their background, their experience, their desires, their culture. All of those factors play into what's meaningful for a person. And again, here's just a couple more of those guides about health and well-being and kind of how to live and to celebrate life and leisure. And so that kind of sums up a little bit of kind of the general aspect of our talk, but we're going to open it up for questions and conversations now. But I wanted to at least give you, my direct contact information is here, and I can certainly take, questions from you. You can feel free to email me or others. Here's my phone number. You can reach out if there's something specific. And again, we have all of our navigators are on the phone. You can make a call and talk to any one of our specialists. We'd be happy to support you. But we're gonna open it up now. So if you have a question, I know you can put that in the chat, as I was saying earlier, or you can put yourself on video and raise your hand, and we will we'll call on you to ask a question, and you're welcome to ask questions about, from Anne or from myself. And I see there's a few questions in the chat here that I will I can bring forward, but let me just stop sharing my screen now. And right, so I'll just warn you all that if you do turn your video on, other folks will be able to see you in the room. That's okay with us, but I want to give you at least that heads up. There's a couple questions here in the chat though, Anne, and I think I may punt these to you. So one of the questions was, is there a connection or association between FTD and Parkinson's disease?
There is usually not, but there is one variant where there seems to be an association, but that's very uncommon. But regarding Parkinson's disease and Lewy body disease, another part of the question was, I've been getting, is there a test that can rule out Lewy versus Parkinson's disease? And there is not specifically a test that can rule it in or out. A lot of testing is done with looking at the clinical picture to see it, but the definitive diagnosis can't be made by a test. Unfortunately, it's kind of a clinical picture ruling out other things it could be, and still there, it's not definitive.
What we didn't spend a lot of time tonight talking about how do you get diagnosed. That's a kind of a different talk. What should I be looking for as far as diagnosis goes? What's normal aging? That's another talk that we do on brain health, and I'd encourage any of you who are kind of interested in that to tune in. And I see there's also some questions about medications and kind of treatments. And again, you know, that wasn't the conversation for tonight. We're happy to talk a little bit about that, but I think we could probably, there's lots of information about medications and some of the risk factors, particularly some of the new ones that are out. Like I had mentioned, there are some new disease modifying medications, some infusions that have been approved by the Food and Drug Administration that are now available. And we can certainly, you know, direct you to some resources that can help you to make a decision, or what kind of questions you can be asking, you know, your healthcare provider for that. But Anne, do you want to just very briefly speak about kind of what medications are out there?
Sure. So,
Symptoms?
right. So there are some medications, as Stephanie was saying, for early dementia that have been approved by the Food and Drug Administration, that are antibodies to amyloid, and they are considered they're new. They are IV infusions and have some side effects and some warnings for a very special group of people not to take the medication. So that has to be a well thought out conversation with your neurologist, or and not with your primary care physician. I think it needs the specialty of a neurologist that understands it. There are some other medications that have been on the market for years that try to help with symptom control, or and those include acetylcholinesterase inhibitors, like and then another NMDA medication. Those two types of medications seem to help sometimes with people functioning a bit better, and it seems to help some people and not others. So that's, again, a conversation you need to have, or a trial. And then for people with vascular disease, treating high blood pressure, high cholesterol can be beneficial and potentially slow vascular issues. And then lifestyle changes have been shown to be beneficial. A fruit and vegetable, a Mediterranean diet, or a diet high in fruits and vegetables and minimum processed foods. Exercise has been shown to be beneficial. Cognitive stimulation therapy, which is something that can happen at CaringKind, has been shown to be beneficial. There's a host of things, and again, I think it's so many. I guess I would warn against a lot of vitamins that are marketed that have not been shown to be beneficial and may just be expensive for you. And make sure that any medications like that you don't interfere with your other medications. So talk to your doctor or your pharmacist about that. I think those would be my high points.
Great, thanks, Anne. I appreciate the plug for our cognitive stimulation therapy program. That kind of the new infusions that are available out there, what they basically do is they don't cure Alzheimer's. What they do is they slow the progression. We believe that there are programs like cognitive stimulation therapy that have also been shown to enhance cognition and to slow. And so if you're interested in learning more about those, you know, feel free to reach out and we can certainly give you some more information. Any other questions? I know that there was a question in the chat. This recording will be available and available on our website. We're in the process. We're going to have a new website, and hopefully by the new year, you'll see kind of our new learning hub where all of our videos and slides will be easily accessible to you. They're available now on our YouTube channel, but watch for the email that will come out to you on a monthly basis with upcoming webinars, and there'll be links there to the videos and to the slides that we've shared. But yes, absolutely, we're making these available to the public for you to share. Any other questions? I know we're a little bit beyond our time, but we want to make sure that you have questions. This question about upcoming talk about clinical tests for dementia. We don't have those planned, but we can certainly explore that. There are a number of different tests that are available now, kind of historically. You know, you kind of go through a series of tests. And again, from a diagnostic standpoint, you know, it's all of these diseases, you know, they present in different ways, and there historically been what's called a clinical diagnosis for determining what kind of disease a person has, where you kind of rule out other things, and then based on symptoms, you would make a determination, the physician would make a determination on what a person has. This is now changing, kind of we're really in the cusp of new technologies where we have much clearer diagnostic tests, particularly for some of the dementias. So we have better PETs, we have better scans, more definitive scans where we can actually see kind of the brain changes. You know, they're more precise. There are some blood tests that are actually have pretty good reliability. They're not available in the US now, but the future for getting those differential diagnoses and to get easier diagnoses are certainly on the horizon, which is good news for us. I know there was a question above about alcohol. I think you have there's a question about whether there are any studies done on people with Alzheimer's and dementia and addictions. I know there is work kind of looking at those specifically. I'm not aware of any, but we could certainly look those up. And especially if you were looking at something like a clinical trial.
Right.
We could certainly, help you get plugged into folks who would be able to better address that question for you. Okay. Any other questions? Did I get them all in the chat there?
I think you did.
Awesome. Great. Right, neurologist. Good news is that there's kind of, if you're having a difficulty getting a neurology appointment, you can reach out to us. We've got a few groups that we work with. There's also a new group that's working on kind of all via telemedicine that we can put you in touch with. So I know it's been historically very difficult to get diagnostic testing. I see the shout out for the occupational therapist there in the chat too, so appreciate that. Getting connected to a qualified occupational therapist is very helpful for individuals. We're actually going to be stay tuned, we have an upcoming webinar on home safety that's being led by an occupational therapist to talk about different strategies and ways to support people at home and in independence. So watch for your emails for that. And hopefully that'll be helpful. But we're approaching 15 minutes, or we try to end by 7:15. But thank you all so much. I hope that this was helpful for you. If there are particular talks you'd like to hear from us, please let us know. We're also looking for feedback on particular days of the week, times that are helpful for you or family members. If you know of people who aren't able to attend our webinars or seminars, who need them at a different day or time, please let us know that as we're doing some planning. We would love to be able to make sure that we're providing the education that people are looking for and are offering it at days and times so people can actually access the materials. Again, if you're local, we'd love to see you at Central Park on Saturday at 10 o'clock. Stay tuned and please plan to attend the Hallis lecture with Dr. Ken Vidoka on November 19th. And we look forward to seeing you all again. And feel free to reach out if there's anything that we can help with, or if you have more questions, call our helpline and talk to one of our navigators so we can direct you appropriately. And that's 646-744-2900. Thanks so much and have a good evening.